In this snapshot, we will be providing a basic compare and contrast overview of some of the more common anxiety disorders, including generalized anxiety disorder, panic disorder, agoraphobia, specific phobia, and social anxiety disorder. Anxiety disorders are the most common psychiatric disorders. About 20% of the population experiences an anxiety disorder in any given year, and 30% of the population will experience one during their lifetime. Anxiety is a common primary presentation in primary care and can also heighten physical symptoms. In addition to worry and irritability, anxiety disorders can present as a variety of physical symptoms, such as headaches or tension in other muscle groups, nausea, constipation, diarrhea, or other GI symptoms, dizziness, and sleep difficulties. Adults may be more likely to verbally describe feelings of worry than children, who are more likely to present with physical concerns. Why the brain-body connection? The brain and the body are hardwired with a protective system that has allowed humans to survive evolutionary threats. Fear and anxiety activate the amygdala, which is part of the limbic system in the brain. I like to call the amygdala the fear factory of the brain, although it's really more complicated than that. The amygdala senses fear and activates the autonomic nervous system, manifesting in physiological symptoms to prepare us to fight, flight, or freeze in response to a threat. Without this system, humans probably would have been eaten by saber-toothed tigers years ago. Fear is a normal adaptive response to an existing threat. It's usually short-lived and subsides when the threat disappears. Anxiety differs from fear in that there's an anticipatory element to it. It's not in response to an actual in-the-moment threat. With anxiety, a person worries about vague or potential future threats. In general, anxiety disorders are characterized by excessive fear or anxiety and are often accompanied by behavioral disturbances that function to diminish worry. Avoidance of an anxiety-provoking stimulus is a common behavior in anxiety disorders. In anxiety disorders, the amygdala becomes hyperactive and small cues lead to reactions and responses that are out of proportion to an actual threat. At least, this is my simplistic big picture view and a place for you to start. Without treatment, anxiety disorders tend to persist. As we review each anxiety disorder, you will learn that each one is characterized by a theme. Keep these in mind as you start to develop your overall diagnostic framework. There are some important key concepts to keep in mind when you are studying the anxiety disorders. Anxiety disorders are differentiated from simple fears in that they are persistent and last in the realm of months. If a fear lasts only a short time, it is often a normal transient fear. Prior to making a diagnosis of an anxiety disorder, you must consider the developmental level of the patient, as some fears are developmentally appropriate at some ages and therefore are normal. Lots of medical processes overlap symptoms of anxiety. A few common medical causes are listed here, but you need to be guided by history and presentation. Obtain a thorough medical history, vital signs, and physical exam. If a patient meets criteria of an anxiety disorder, but the symptoms are in the context of an active medical condition, the diagnosis is most likely anxiety disorder due to another medical condition. Similarly, several medications and substances have activating side effects that can mimic or worsen anxiety. Assessing caffeine use is particularly important as it is a commonly used substance with stimulant effects. If a patient meets criteria for an anxiety disorder but the symptoms are all in the context of a substance effect, the diagnosis would likely be substance or medication-induced anxiety disorder. You also want to assess if another psychiatric disorder better explains the patient's presentation before making a diagnosis of an anxiety disorder. Anxiety symptoms that occur after a recent stressor is more consistent with an adjustment disorder with anxious features. As most anxiety disorders require symptoms lasting over 6 months, you should seriously consider adjustment disorder if symptoms have lasted less than 6 months and they're in the context of a recent stressor. You also need to assess whether the individual has ever met criteria for another psychiatric disorder, such as bipolar disorder, or has another psychiatric disorder which would better explain their symptoms. A thorough psychiatric review of systems is a good way to help narrow down your psychiatric differential diagnosis. In the case of anxiety disorders, there's often a typical identifiable time of symptom onset that can be elicited in the HPI. Some personality disorders have really prominent overlap with some of the anxiety disorders. In the case of personality disorders, the symptoms are almost always present to some degree and don't present in episodes as they do in the anxiety disorders that we are about to talk about. Let's start with generalized anxiety disorder, or GAD. In this disorder, which is pervasive in that it lasts at least 6 months and the symptoms occur more days than not, the anxiety disorder is about a lot of different themes. People with GAD worry about anything and everything: natural disasters, safety, finances, the future, work, so on and so on. The worry is hard to control and excessive for the situation, and the anxiety is accompanied by at least 3 additional symptoms, although only 1 is required in kids, including restlessness, fatigue, which makes sense because it's exhausting to worry this much all the time, concentration problems, irritability, muscle tension, or sleep problems. It's common for GAD to present as insomnia and physical symptoms, especially in the primary care setting. The second anxiety disorder we will talk about is panic disorder. Panic disorder is characterized by recurrent unexpected panic attacks. We will talk about what a panic attack is in a moment. At least one of the panic attacks is followed by at least 1 month of persistent worry about having more panic attacks or their consequences. Examples include fear of losing control, of having a heart attack, or of going crazy, or a significant maladaptive change in behavior related to the panic attack, such as avoiding things that have triggered or might trigger more panic attacks. It should be pretty easy to see how this could lead to dysfunction in someone's life. What are panic attacks? A panic attack is a sudden, rapid surge of intense fear that intensifies within minutes and is associated with physical symptoms, at least 4 by technical definition, including sweating, palpitations, trembling or shaking, shortness of breath, chest pain or discomfort, feelings of choking, nausea or gastrointestinal problems, feeling dizzy, unsteady, or lightheaded, chills or heat sensations, paresthesias, which are tingly sensations, derealization or depersonalization, which could be feelings of detachment or that things aren't real, or fears of losing control, going crazy, or even dying. Panic attacks usually subside in under 30 minutes, but they can last longer. And panic attacks can exist without having panic disorder. Remember, to have a panic disorder, a person also has to have a persistent fear of having more panic attacks. Next, we will describe phobias. The word phobia derives from phobos, the Greek word for fear. The theme of phobias is irrational fear of a specific object or situation that is out of proportion to the item or situation itself. Exposure to the object or situation generally induces almost immediate fear or panic. The fear is so severe that the affected person either avoids the object or situation entirely or endures it with significant distress. And the fear is persistent, lasting at least 6 months. There are many different kinds of phobias. Examples include arachnophobia, which is fear of spiders, acrophobia, which is fear of heights, and claustrophobia, which is fear of enclosed spaces, although there are many others. Agoraphobia is fear or anxiety in at least 2 situations. However, the fear is not because of physical attributes of the situations themselves, which would actually be a specific phobia of those situations. The fear in agoraphobia is specifically of being unable to escape or get help in a situation if a panic attack or embarrassment were to occur. There are lots of different situations in which agoraphobia can occur, including using public transportation, open or public spaces, closed spaces such as stores, movie theaters, etc., crowds or standing in line, or being alone anywhere outside of one's home. Again, that experienced fear is significantly out of proportion to the actual danger posed by that situation. As a result of this intense fear, a person may actively avoid situations completely or may demand that someone else be around them to help, or they may endure things like grocery shopping or going out in public only with intense distress. And like other things we call phobias, the symptoms are persistent, meaning they last at least 6 months. It's easy to get confused between specific phobia and agoraphobia, particularly if a person's anxiety is leading to avoidance of a situation. So let's look at an example. Say you have a patient, Sam, who hates going to the movies and out to restaurants. Sam would like to overcome this because it's really affecting his social life. When you ask Sam what he hates about these settings, he describes feeling panicky and needing to know where the nearest exit is at all times. He doesn't like to feel trapped. He doesn't like to go anywhere that he doesn't know the escape plan. What might you call this? If you're thinking agoraphobia, you're right. Now, what if Sam says he hates movie theaters because they're dark, crowded, and that closed-in feeling really freaks him out? That might be more consistent with claustrophobia. Remember that a specific phobia is fear of the situation itself, often related to physical attributes of the situation, whereas agoraphobia is fear of being unable to get out of the situation in the event of a panic attack or something embarrassing happening. In social anxiety disorder, the fears of being judged by others in a social situation. This makes things such as having a conversation, meeting new people, performing in front of others, or being in a situation where one is being observed by other people really difficult. The person fears that what they say or how they behave will be embarrassing or even offend others, leading to rejection. And this situational component almost always provokes fear or anxiety that is way out of proportion to the actual risk, and the person tends to avoid the situation or gets through it, but with really extreme distress. Fear of public speaking, meeting new people, or eating in front of others are common manifestations of social anxiety disorders. And the symptoms are pervasive, lasting at least 6 months. Let's summarize the anxiety disorders. If anxiety disorders symptoms only occur in the context of a medical issue, we call it anxiety due to a medical condition. If the symptoms occur only in the context of direct effect or withdrawal of a substance or medication, we call it substance or medication-induced anxiety. Generalized anxiety is characterized by chronic anxiety about a variety of themes, such as safety, natural disasters, perfectionism, and many others. Somatic symptoms such as headaches, GI symptoms, restlessness, and fatigue are common. Panic disorder is characterized as a history of panic attacks, with the primary fear of having more panic attacks over at least a month. Agoraphobia is defined as chronic worry of not being able to get out of a situation in the event of a panic attack or something embarrassing happening. Specific phobia is chronic fear of a specific object or situation, often related to physical properties of that thing or place, and resulting in interference with daily functioning. And social anxiety disorder is characterized by long-standing fear of judgment or scrutiny by others, or fear of offending others, leading to extreme discomfort or complete avoidance of social situations.